All right. We're all set. I'm sorry, I had forgot to hit the recording button. So as I was saying, I'm pleased to have Dr. Amy Harrington as our instructor for this webinar. Dr. Harrington is an assistant professor of psychiatry at the University of Massachusetts Medical School in Worcester, Mass. She is also the medical director for Acute Addiction Continuum at Community Health Link in Worcester, Mass. So this webinar is being recorded. The presentation slides and the recording from this webinar will be made available to you after the webinar. It may be a few days before we get the information together, but you will receive a link for the recording and the slides. So as I was saying, Dr. Harrington is an assistant professor of psychiatry and also the medical director at Community Health Link. I have just a few housekeeping things to tell you all about. The webinar will be about an hour. Because we have a large group attending, everybody is muted as they come into the presentation. If you have questions during the presentation, jot down your question and we will have the last 10 minutes of the class for you to ask questions. Also, at the end of the webinar, I will share some of the free resources about opioids and addiction from the National Library of Medicine. Oh, there's Dr. Amy Harrington, sorry. I just wanted to let you know there's information also about the National Library of Medicine. Again, some of the useful digital resources about health and medical topics that it has for a wide variety of audiences. For example, consumers, librarians, healthcare providers, public health workers, educators, researchers, and students. And all of these resources are available to everyone and they're free and they're all online. The mission of the National Library of Medicine is to improve public health by making online health and medical information accessible to everyone. Providing free training classes about the resources, as well as providing grant funding opportunities. All of these activities are carried out through a nationwide network known as the National Network of Libraries of Medicine, or NNLM for short. If you find that this webinar is helpful to you, we have one more webinar coming up in our series. It will be taking place on January 9th, and the topic is individualized treatment and understanding the non-pharmacologic components that are part of recovery. And you can just click on the registration link. And so now I'm going to turn the presentation over to Dr. Harrington.
Thank you so much, Susan, and thank you all for having me. I was talking with Susan before the webinar and saying I finished my residency at Georgetown University in 2009 and then came up to Massachusetts in 2010 to do an addiction psychiatry fellowship at BU. And you know, when I first joined the faculty here at UMass, I would often get invitations to speak to medical groups and other health professionals, and it's been interesting in the last couple of years getting invitations from other professionals and colleagues like the Business Journal or the trial attorneys, and now it's wonderful to be able to talk with your association. I have no financial disclosures. And I am going to attempt to use generic names for medications whenever possible, but I will use the words, the terms Suboxone, Vivitrol, Narcan, because these are the terms that people seem to know these medications by out in the community. I'm certainly not endorsing any specific brand or pharmaceutical company, but that's just the language that the patients are using, and so I'll use that language as well. So this is where I work. This is Community Health Link, and so we talk about a continuum of addiction treatment, and I don't have a pointer on here, I don't believe. But just, briefly, I often like to go through the different floors. So in the basement, we have our urgent care, where it's a behavioral health urgent care. So people who want treatment for addiction 24 hours a day, 7 days a week, they can come in. Often they're admitted to the third floor, which is our detox unit, where they're medically detoxed off of opiates or also benzos, alcohol, usually over 5 to 7 days. They go up to our fourth floor, which is what we call our clinical stabilization service, which is basically a post-detox early treatment program. We call ours passages. People are usually there 14 to 28 days, and then a lot of times they go on to halfway houses. Unfortunately, halfway house beds take a little while to open up, and so people will go up to the fifth floor, which is a holding unit. Down on the first floor, we have an outpatient clinic where we use medications like buprenorphine, which is Suboxone, and we also use naltrexone, which is Vivitrol. There are therapists. We have group counseling, individual counseling. So really, we like to look at just treating addiction is a multi-phase process, and we try to coordinate care as best we can. And so the reason I became interested in this field was that when I was in medical school, the first year of medical school, you don't really get to do much. You're in the classroom, and so a lot of people will volunteer at homeless shelters and in order to get a little bit of practice doing actual medicine. And I had a friend who was going to volunteer doing some medical care at a needle exchange program in Philadelphia called Prevention Point Philadelphia, and it seemed interesting, and it actually had a very profound effect on me. I remember very clearly that there was one person who was coming in week after week, dropping off used needles that were potentially could contaminate someone, picking up new clean needles. He came in for some medical concern, and after I addressed that, we talked, do you want to meet with a social worker today? Are you interested in any further treatment? He said, no, I'm not interested right now. And then maybe 6 weeks later, I saw him talking to the social worker and eventually got into treatment. And so what we were able to do is create a safe place where people could come. They felt like they could access treatment, and so when this person was ready, he knew where to turn. So during this presentation today, I wanted to talk a little bit about what the philosophy of harm reduction is as it relates to the treatment of substance use disorders. I want to go into some of the harm reduction strategies that are currently being used to reduce the secondary harm from opioid use. And then, I'm a psychiatrist, and briefly talk a little bit about how comorbid disorders can affect substance use treatment. I'll also talk a little bit about some of the medications that we use. And so, briefly, I always like to give a little bit of background about how did this epidemic get to the level that it's at. It's a historic level of opioid use. And so in the 90s and the 2000s, there really was this push to treat pain more aggressively. And unfortunately, there was a letter to the editor of the New England Journal of Medicine. It was only 5 sentences long, but it basically was reviewing charts for Boston Medical Center, where I did my fellowship, and looking at the number of people that were prescribed opioid pain medication and the number of people who had a documented substance use problem afterwards, and it was less than 1%. And so what ended up happening is this lore got out there that if you take opioid pain medication as prescribed by your doctor, you have a less than 1% chance of developing some sort of problem with it. And unfortunately, we know now that that's not true, but that became what people would say. And I remember learning this in medical school and you know, even during residency. And so what ended up happening is people started prescribing opiates more and more. The pharmaceutical companies were really marketing medications like OxyContin, which is a long-acting opioid pain medication. They would market directly to primary care doctors, and this was an unusual twist because in the past the medications were usually marketed to specialists like orthopedic surgeons and oncologists who treat cancer. And so primary care doctors were being, you know, not just encouraged to prescribe opiates, but they were being told if you weren't prescribing it, you were being a bad doctor, you were practicing bad medicine. You know, I actually remember learning in medical school that pain is the 5th vital sign. So, you know, when you're checking temperature and blood pressure, pulse and respiration, you have to ask everybody to rate their pain on a scale of 1 to 10, even if they were coming in not for a pain-related complaint. You know, if somebody was going in to you know, refill their birth control, for example, they would get asked rate your pain on a scale of 1 to 10, and you know, so now pain was being focused on more. The Joint Commission on the Accreditation of Healthcare Organizations, which, you know, if any of you have worked in a hospital know, is they just really run your life, and you know, they said it's a patient's right to a full pain workup when pain is not easily characterized or treated. And so over the next decade, the prescribing of opiates went up and up and up, and as you can see, as the prescription went up, the rates of opioid-related deaths also went up, and the number of people seeking treatment for opioid use disorder went up as well. And so just sort of looking here in where I work in Worcester County, you can see that over the last, in particular over the last maybe 5 years, things have really increased very dramatically. One of the big things is we're seeing the introduction of fentanyl into the recreation heroin supply, and as many of you know, this is a synthetic opiate that is much, much stronger than anything that, you know, than normal heroin. And we're seeing this mostly in certain areas, you know, so the West Coast, for example, you'll find people in California, there isn't fentanyl the way that it's here on the East Coast, and it's being seen in a lot of the opioid-related deaths. So, you know, when you're dealing with something as widespread and an epidemic like this, I think you really have to have as many tools in your toolbox to address it. I don't think there's one answer to how we're going to get out of the situation. And so harm reduction is a really important strategy, and it's basically to come up with ways of creating a safer use so that people aren't experiencing the negative consequences and are hopefully able to minimize the harm, so that when they, you know, this unfortunately with this disease is characterized by often requiring multiple doses of treatment before it goes into full remission, and so often people have to access substance use treatment multiple times before it sticks. And when people leave treatment after a certain amount of abstinence, that's a huge risk period of overdose. But you know, you want to create a safe space, meet them where they're at, so that when they are ready to come back to treatment, they know where they can turn. I don't know if any of you saw this. This was back in June of this year. This was on CNN.com. The opioid epidemic is so bad that librarians are learning how to treat overdoses. And if any of you had a chance to read through this article, a lot of libraries were seeing was that, you know, people would come in to use the facility during the day. They would go into the bathrooms and they would overdose on opiates in the restrooms. And there is a medication called Narcan that is anybody listening to this can probably get from your pharmacy. Certainly anybody in Massachusetts can walk into any pharmacy and get this. It's a medication that will reduce an opioid overdose and buy people time for the ambulance to get there and get them onto further treatment. And so in this particular article, librarians in various communities were being trained in how to administer this, and several of the people interviewed had administered it multiple times to multiple different people. So, but thinking about just how many lives had been saved by that sort of intervention. So this is called bystander administered intranasal naloxone. Some of you may have heard it referred to as intranasal Narcan. So Narcan naloxone is a medication that EMTs and emergency room doctors have been using for many, many years. It's an opiate blocker, so it reverses an opiate overdose. In the top picture over on the right-hand side, you can see it's a vial. Usually it would be administered either intramuscular or intravenous by a medical professional. In order to turn it into something that a layperson could administer by putting it into the nose and squirting it, you have to attach this thing called an atomizer to the top. If you look closely at it, it's kind of a complicated thing to put together, and you can imagine if somebody's dying in front of you, you might not remember all the steps that you have to take to put it together correctly. So the picture below is it's just a one squirt bottle that you just put it in the person's nostril and you squirt it, and the medication gets absorbed, and you can potentially save somebody's life. I will say, just from my own personal clinical experience, because fentanyl is in the heroin that people are buying, and it's so strong, we usually go through 3 or 4 of these before the paramedics get there. We just had an overdose last week that we had to use 3 of them, and the person walked away, and it was a very it's very impressive to see somebody who's blue in the face and dying, and then they literally 15 minutes later are walking away. Unfortunately, this person did not access treatment, but we did offer it. So, the thing that is funny is that people, there's this idea that if you make intranasal Narcan available, that people are going to want to go out and use more heroin because now there's an antidote, so people are going to say, this is safe for me to go out and do, and so I'm going to start using heroin more. Just sort of the smell test for me, that's kind of ludicrous, but there actually are data out there, and so in studies that were conducted here in Massachusetts, when they were initially piloting distributing Narcan, intranasal Narcan to people in the community, the areas where there was high implementation, there were lower rates of death from opiate overdose than in areas with low implementation, but there was no significant difference in the rates of overdose. And so people were still using and overdosing at the same rates, they just were dying less from it. So you could extrapolate from that there was no increase in the actual drug use just because it was available. And so the syringe exchange programs, like the one I was talking about in Philadelphia, the concept of this is that you provide free sterile syringes in exchange for ones that have been used. And so we would distribute Sharps containers to people, and they could put their syringes in there, then they would come back in, they would turn those syringes in and get new needles in exchange. In addition, we would provide things like sterile water for diluting the opiates. And so when you buy heroin, it's in a powder. You have to dilute it into some sort of liquid so that you could inject it. I've heard stories of people using toilet water, people using their own urine, people using whatever liquid they can find, you know, puddle water, anything they can find to dissolve it. Also just alcohol pads to sterilize the injection site. We would do education for people on this is how to sterilize an area so you don't get a skin infection like cellulitis, so you don't get an abscess. We would have on-site medical care. We would vaccinate people against hepatitis A and B. We would offer testing for hepatitis C and HIV. And like I said, we had people there who could help people get into detox or other levels of treatment if they so desired. And so something that's been receiving a lot of press in Massachusetts lately has been the concept of a supervised injection facility. And so these are places that they already exist in Canada, in Australia, in Europe. So people can bring the drugs that they purchase on the street, bring them in, and then inject in a clean, well-lit, supervised area. And then they can also dispose of the medical waste afterwards appropriately. You know, because a lot of the secondary harm that happens with the drug use is that people will they'll purchase what they're gonna use, and then they don't inject out in public. They go into a dark, secluded area where they're not going to be found by police. Obviously, if they overdose, they're much less likely to receive any medical attention. Also, these are often an area where there's a lot of criminal activity, and so if somebody stumbles upon someone who is compromised because they're intoxicated, they're at a greater risk of being victimized physically or robbed or something like that. You know, and then also in these areas, you see a lot of biohazard waste. You know, I'm the mother to a 14-month-old, and I'm constantly pulling cigarette butts out of his hands and wood chips out of his mouth at the playground. And so the idea that he could accidentally pick up a hepatitis-infected syringe is very real to me. And so in these areas where these programs are implemented, there are significant impacts on public health. So they use the term shooting gallery, which is a pretty derogatory term, but you might hear that in the literature. But these already exist in Australia, Canada, Europe. So there's a lot of research out there. One in particular in Australia, it's the Sydney Medically Supervised Injecting Facility that's been open since 2001. And the research shows that they have decreased rates of injecting in public places. There was no change in the actual overdose rates, but there were no fatal overdoses at the facility, and that makes sense. If somebody does have an overdose, they're medically trained people who can, administer Narcan. They actually didn't find any measurable impact on infectious disease transmission. But just if you're injecting in a dark place, you're going to have poor visibility, might not be able to see the veins as well. You can remember from the picture. I'll just go back real quick. The picture, see how well lit it is. People are going to be able to actually do the injection in a safer way. There's no change in the crime rate. They talk about this honeypot effect. Like if you open a supervised injection facility, you're going to draw all the criminals to your area. They did not find that. And that's because the facility was placed in an area where injection drug use was already high. And so, here in Massachusetts right now, there's a place at Boston Healthcare for the Homeless where people can go after they've used, and they can be observed in a safe place. And excuse me, I know someone who was working at that and sort of described it as just sort of barca loungers where people are hanging out, and he said, it was constantly full. There was a huge demand for being able to be in a safe place. And the way the laws are structured, we unfortunately cannot open a supervised injection facility. It would require some sort of executive order for us to be able to do that. But the Massachusetts Medical Society spent a year studying the concept of doing a pilot, and they recommended at least piloting some sort of facility in Massachusetts. And so I'd love to see this go into practice and see if this does help, but more to come on that. All right, so now moving on from harm reduction to treatment, and I really wanted to make that point clear that I'm going to be talking about some of the medications that we use to treat opioid use disorder. I do not at all put that in the same category as harm reduction, because harm reduction is the disease is still active, but you're trying to reduce the secondary harm. We're talking about treating the disease so that it can go into remission. And so we use a lot of different strategies in the treatment of opioid use disorders. There's acute detoxification, which can happen in an inpatient setting. We can also do it in an outpatient setting. There's residential treatment, like I talked about the Passages unit where people can go for 28 days. Outpatient therapy, and I'll talk a little bit about the different treatment modalities. Peer support, so things like 12-step meetings, AA, NA, Smart Recovery, those kinds of programs. And then, you know, medication as being one piece of that. And so I'm constantly telling the patients that come in, you know, Suboxone is not a pill, it's a program. You know, the actual medication that you put in your mouth is just one piece of it. We also do urine drug testing. We also do group psychotherapy. We do individual psychotherapy. If people are struggling, we will, you know, require them to either do some sort of intensive outpatient or even residential treatment in order to stay in the program, because the medication alone does not work. You need to have all the different pieces in place. The different medication options I'm going to talk about are full opioid agonists. So these are things like methadone, heroin, morphine, OxyContin, Percocet. They all bind to the opiate receptor and activate it as much as it can, up and up and up. The more you take, the more effect you get. Suboxone is a combination of two medications. One is buprenorphine, which is an opioid partial agonist. So it binds to the opiate receptor and activates it more and more up until a certain point. And then the more you take, you don't get any additional effect. There's that ceiling effect. And so, you know, people report sort of feeling less high off of it, having less of the nod, they call it, and are able to function a little bit better in some of the things like home and work and things like that. And then there's also opioid antagonist treatment. So Narcan is an opioid antagonist. There's also naltrexone, which is an opioid antagonist that you've probably heard of as Vivitrol, and I'll talk about that a little bit more. So methadone has been around for 50 years or so. Full agonist at the mu-opiate receptor. Its half-life is about 22 hours, so that makes it an ideal medication for once-a-day dosing. The problem is it's very tightly regulated at a federal level, and so the regulations that are in place, there's really not a ton of wiggle room in terms of changing how you're going to do things. You have to go to the clinic every day for a really long period of time, which means it can be kind of challenging to get what are called take-homes or take-home doses that you can take on your own. Eventually, a lot of people can work up to the point where they're going in once every 2 weeks, and they'll get one dose there and then 13 take-home doses. But, you know, just the environment of where methadone clinics are, you know, often people that are there for the wrong reasons will hang out. And I've been told by a number of people that you know, that their dealers will seek them out at the methadone clinics in order to try to get their business going again. And so, you know, a lot of people don't want to be on methadone for the reason that it's just these lifestyle issues. You know, from a medication standpoint, there are some people that need that full agonist. You know, their cravings are strong enough that, you know, they need that full effect. People that have pain issues, methadone is a much, much, much better pain medication than buprenorphine is. And so there can be a lot of medical reasons why I might recommend methadone over buprenorphine or Suboxone, but people make a decision to go on Suboxone more for the lifestyle reasons. And so, you know, just a little kind of Suboxone 101. So I have a lot of patients that come in and they say to me, I know how Suboxone works. It's got a blocker in it, so if you take any other opiates, there won't be any effect. And I'm always like, you know, should I correct them? Because that's basically the idea. It's not exactly the right answer. So, you know, sort of psychopharm 201 if you are really interested. So remember that graph I was showing, that the buprenorphine has less of an effect, but it binds much more strongly to the mu opiate receptor than the morphine or methadone or heroin does. So if you take buprenorphine, the partial agonist, when there are full agonists in your system, then you feel like you're going into withdrawal because you're going from a full agonist to a partial agonist, but it's the blocker, the naloxone, which is Narcan that's in it. The reason why that's there was that you know, these concerns about diversion, and so it really only goes into effect if you inject it or snort the pills inhalationally. The way you take Suboxone is you put it under your tongue and you let it dissolve. It takes, you know, 5 to 15 minutes to dissolve, and it gets absorbed through the blood vessels that are under the tongue. If somebody tries to shoot it or snort it, then it goes into effect and you know, theoretically could block the effects, although from what I hear from people, it doesn't always work that well. So, you know, like most people like buprenorphine for the lifestyle reasons. You come to a doctor's office, you know, you walk in my office and close the door, the people in the waiting room have no idea why you're in there seeing me. You can get up to a month's worth of medication at a time. I'll tell you, we don't do that when people first come in. The way our program is set up, people come in, you know, at least once a week for the first several months. They come to a group therapy. If they come to the group, then they get their prescription. We do weekly tox screens. Then once it seems like people have stabilized, then we'll back off, maybe go down every 2 weeks for a little while, and then eventually, you know, people get on a month's worth at a time. But we only do that when we have good clinical evidence that they're stable. And so because the opiate effects of the buprenorphine level off, some people prefer the fact that they feel like they're more alert and they feel less intoxicated by it, and feel like they're able to function a little bit better. It comes as a tablet, and it also comes as a film. And if you notice the picture on the right, you can see that there's a barcode on the bottom there. So the film is great if you let's say somebody is arrested and is found to have it, the police can scan that barcode and find out who the medication was prescribed to originally, and they could theoretically arrest the person that it was sold to originally for diversion. And, you know, and so there is sort of this move to try and use these kinds of formulations that have these diversion protections. Unfortunately, it's much more expensive, and so a lot of the insurance companies won't pay for it. Another benefit is that because it's packaged in the way that it is, it's a lot harder for children who stumble across it to accidentally overdose. So a lot of insurances will pay for that formulation if you have young children in the house. And then, so the other one that people have heard of is Vivitrol, which is naltrexone. So again, this is an opioid antagonist. It's available as a pill that you can take every day that goes by the brand name Revia. Unfortunately, you need 85% adherence in order for there to be a therapeutic response. And people forget to take medications. And so there is a once-a-month depot injection that's currently available, and that's called Vivitrol. So basically, once a month you go in, to the office and you get this shot which has a month's worth of medication and you don't have to worry about it for the next month. And I will tell you, I've had some patients prefer the oral form, partly because by taking a pill every morning, they say it's a reminder to them every morning that they're committed to their sobriety. I've also heard some people report that towards the end of the month, they'll notice that the effects start to wear off a bit. And so sometimes we'll give the oral medication for the last month just to help boost the Vivitrol or get people through that period. It would be great if we could dose it more frequently, but it's, I think, $1,000 a shot, and so most insurance companies aren't paying for it. But it's certainly $1,000 a month is a lot less expensive than the cost of ongoing heroin use. You know, we see that a lot of, I'm concerned because I see a lot of people, like the court systems, like pushing people towards Vivitrol, not really because it's medically indicated, but because they like this idea that it's not an opiate and that it can't be diverted. And you know, I think it's great to have many different options, many tools in our toolbox, but not everybody is right for Vivitrol. Another thing is I see a lot of people that are very involved with AA and NA. Unfortunately, there's still this perception in those organizations that you know, methadone and buprenorphine are just replacing one drug with another as opposed to being medical treatment for this illness. And so, you know, it's a shame that that's still out there. We're working to try to break that stigma, but I see a lot of people that are very involved with AA or NA that decide to go with something like Vivitrol just because it's a little bit more socially acceptable in their social circle. All right, and so what about treating co-occurring psychiatric disorders? I want to stress that having co-occurring psychiatric disorders is really the rule, not the exception. So in the National Epidemiologic Study on Alcohol and Related Conditions, people who were seeking treatment with alcohol use disorder, 40% of them met criteria for mood disorder, 33% anxiety disorder. Treatment seekers with a drug use disorder, 60% had mood disorders and 42% had anxiety disorders. You know, just in terms of my own personal experience, a couple years ago I was doing a quality improvement project at Community Health Link trying to increase access to psychiatric care for people who were admitted to the addiction continuum to our Passages unit, that early recovery residential program. You know, those of you who look closely at the numbers will notice that I actually made things worse before I made them better. But what I did find really interesting was that throughout the entire course of this 2-year project, every time I measured the number of people that met criteria for a number of people who were admitted to the Passages unit for treatment of a substance use disorder, 2/3 of them also met criteria for co-occurring psychiatric disorder, and that remained constant throughout the entire study. So really 2/3 of the people that come through our door could benefit from having psychiatric care. And as you can see, we're still falling behind in terms of actually getting people connected to treatment. And this is on par with what's going on a national level. And so for people that have co-occurring substance use and psychiatric disorders, the majority of people, more than half, get no treatment at all. Maybe 1/3 get mental health treatment only, but the number of people that get treatment for both is only about 8.5%. And unfortunately, having a substance use disorder can have negative impact on the course of a psychiatric illness. People who have co-occurring disorders are less adherent with their psychiatric medications. They are more likely to be psychiatrically hospitalized. Often these hospitalizations are shorter but more frequent. Increased risk of victimization, increased suicide ideation, and also completion of suicide and then higher rates of side effects from medication. But like I said, I feel like we're in a crisis right now in terms of being able to access mental health providers, and I see a lot of people in my work that feel like, well, I'm a mental health provider, I'm not going to treat somebody that has substance use, that's the other person's job. And we really need to get away from thinking it like that. It used to be that we looked at treating co-occurring addiction and psychiatric disorders, that you would do it sequentially. So treat the addiction first and then treat the psychiatric issues later. And we're really no longer looking at it that way, that treating both simultaneously is going to have better outcomes. What we see a lot is what we call parallel treatment. So, excuse me, you've got one group of providers treating the addiction, and then you have a second group of providers separately that are treating the psychiatric issues. And what would be ideal is to work more towards an integrated model. So you have one group of providers that is treating both the addiction and the psychiatric issues together at the same time. And so I know Dr. Gonzalez in January is going to be talking a little bit more about the non-pharmacologic treatment, but just stressing that I don't look at medication alone as enough. You need to have the therapy going on as well. So there's relapse prevention therapy, which is really looking through what are your triggers, coming up with plans for how you're going to handle situations before you run into them, so you already know what you're going to do. Motivational interviewing, which is a way of sort of talking through somebody's reason for use, using more statements as opposed to questions, because that can come across as less judgmental and elicit less defense from the person you're talking with. Cognitive behavioral therapy, contingency management. So if you've ever heard people saying, oh, they pay people to not use drugs, they're probably talking about contingency management. So for example, I had a friend at BU who did a study where for people that were on the methadone clinic who were still testing positive for cocaine, for every negative urine, they got a negative urine that was negative for cocaine. They would get one draw out of a bag, and they might win a prize, they might not. So if they had 7 negative urines, they would get 7 draws out of the bag. And it showed that their rates of cocaine use went down pretty dramatically. And so again, whatever way you can get the use to go down. I mean, if you're using a certain amount of money to prevent people from using, as opposed to using the same amount of money to treat the negative consequences of them using, I often say, we gotta, the doctors sometimes forget that they're scientists, and they let their amygdala take over when it comes to treating substance use disorders. I mean, our goal is to, our goal is to reduce illness, not kind of worry about people's morality. We'll let the priests worry about that. Let us focus on treating the illness. And so there's also 12-step groups. There's a form of therapy called 12-step facilitation therapy, which sort of helps elicit reasons why people might not want to engage in NA or AA, and help get people more engaged in those kinds of programs. So I do get the argument not to treat with medication, because it used to be people would say, your depression, your anxiety, your psychosis could be being caused by your alcohol or drug use. So let's wait and see if the symptoms go away with abstinence. I think in the past, when our medications were, lithium and Valium, these are medications that had much different side effect profiles. They were riskier medications. Nowadays, we're talking about, selective serotonin reuptake inhibitors, so Prozac, Paxil, Zoloft. They're much better tolerated. And then, I think the risks are less in relation to the potential benefits. Also, in my own personal experience, really we have to focus on the social factors, the social determinants of health, because that can impact adherence and the success of treatment. So just kind of thinking about what I do in my own personal work. So the research suggests that there's absolutely no reason to delay treating someone who has a co-occurring psychiatric disorder if you're also treating their substance use. And so, you know, one of the things that I do is I'll do psychiatric consultation for people that are admitted to the detox unit. And if I find that they say, you know, I've been in treatment for years and years, I'm on fluoxetine, which is Prozac, I know that it works, I just need to get back on it. These medications take at least 6 weeks to start having efficacy. So I think the sooner you start it, the sooner you're going to get it to levels in the body that are going to be effective. So I do try to restart those kinds of medications. But also, you know, focusing on the social determinants of health. So if somebody's homeless, trying to get them connected with housing, you know, trying to get people into social programs if they've got legal issues, trying to help them address those. We, you know, do try to connect people with substance use, whether it's a substance use treatment, whether it's sort of outpatient counseling, or if it's a residential program, or if it's a halfway house. A lot of times what I do in the consults is I do focus on symptom relief in order to try to engage people in treatment. So one of the challenges I find is that people are used to, I take a substance and I feel an effect right away. And, you know, trying to, you know, encourage them that, you know, you want to take this medication that's going to take 6 weeks to work. It's ultimately going to have a better effectiveness in terms of your overall treatment. But it's going to take a long time to work. Sometimes that can be a little bit challenging. So you know, finding, you know, medications that help people sleep, you know, that if that's something that's really distressing to them, get that started right away, and then they might be a little bit more open to trying a longer acting medication down the road. And then finally, there are a lot of medications that, you know, 2 birds, 1 stone. So medications that we found that can have an effect on mood or anxiety, that can also have an effect on lowering substance use. Topiramate, for example, is something that's, it's not FDA approved for anxiety, but some people say that it helps reduce their anxiety symptoms, but there is a growing body of literature that can help reduce alcohol cravings. And so sometimes medications like that can be helpful. Naltrexone, you know, like I said, it can reduce opioid and alcohol use, but it also can lead to weight loss. And so if somebody has, you know, something like schizophrenia and they have to be on, you know, a medication that causes a lot of weight gain, adding the naltrexone as well can have that added benefit of reducing weight gain. So trying to find things that are going to be, that'll simplify the regimen and address both conditions. So in conclusion, harm reduction strategies can reduce harm caused by drug use, and they're a really important tool for engaging people who have addiction with the healthcare system. Medications like methadone, buprenorphine, naltrexone, they have an effect on the brain by giving the brain a chance to heal and improve communication between the different areas of the brain. And co-occurring disorders, co-occurring psychiatric disorders are common and are best treated by an integrated multidisciplinary approach. And here are some of the articles specifically about some of the harm reduction mechanisms that I talked about. So thank you so much.
Thank you so much, Dr. Harrington. That was a lot of information, and I really want to go back and process some of the things that you talked about. And I think that is a really good segue into what I wanted to tell our audience is that the National Library of Medicine has a lot of great information about opioids and addiction. And if you have some general questions, using Medline Plus, which is the website on the left, is a great place to start. You can start with clicking on basic information and then progressing to related issues. There are also links that bring you to research. There are specific pages just for women, for teens, for children. Medline Plus also has patient handouts that can be printed out and distributed. I also wanted to let you know that the National Library of Medicine recently created a opiate addiction and treatment portal so that many of the resources that we have are all in the same place. And the site provides you with links to resources like videos, reports from the Surgeon General, even lesson plans on prevention for students, related drugs for treatment, information on prescribing opioids, the effect of opioids in pregnancy, neonatal abstinence syndrome, data trends about this health epidemic, and first responder info and resources about opiate addiction as it relates to disaster preparedness and public health. One particular resource that I wanted to just let people know about is our the National Library of Medicine Pillbox resource, and it's just a quick tool where if you say you found one of these pills on the nightstand of your friend or family member and you didn't know what the pill was, using Pillbox, and this is the website, and again, all of this is free, you can basically type in the characteristics that it asks you for, you know, such as shape, color, size, scoring, and it returns matches to the information that you gave it. And when it returns its best guesses, it also gives you information that you can expand to basically learn more about that particular pill or drug. Another resource that is new that we have started to offer is the opportunity for groups to learn about health and medical conditions through our graphic medicine book club. Graphic novels provide health information in comic format, which can help with understanding health issues and illnesses. So if you're an audience member who provides programming that includes addiction, you know, as part of your program for high school students or adults, and you live in the New England area, you are able to borrow our graphic medicine book club kit, and we will mail it to you, and you get return postage. These loans are for 6 weeks at a time. They're free of charge. They're great for students, faculty, professionals, and the public. Some of the other subjects besides addiction are aging, AIDS, cancer, epilepsy, and grief. And just the last part of our resource, resource list, this is just an infographic about all the different current health topics that the National Library of Medicine has resources for. So if you would like to have access to these links, you can just click on this website and it will make the link live. All right, so we have some time for questions, and I would like you to use the chat box to ask Dr. Harrington any questions that you may have about this subject, or even any comments you have. While we're waiting for the first comment, one thing that came to mind when you were talking about it took 2 or 3 times with the Narcan, Does that mean that people should try and have multiple doses with them? And what does it look like when a person is not responding? Like, how do you know they're not responding? How quick does it take effect?
Yeah, so the recommendation is to repeat every 3 to 5 minutes. So if somebody doesn't respond right away, repeat it about 3 minutes later. I think it's important for everybody to be, CPR certified, because one of the things you should also be doing as you're waiting for the paramedics to arrive is to be, administering CPR if necessary. Yeah, it's tricky because these, unfortunately the Narcan that's easy to use is expensive. The ones that is a little bit more complicated to put together is much cheaper, and so, a lot of insurance companies will only pay for the one dose. I mean, hopefully if you're in a group, everybody's got their Narcan on them, and you can all sort of pool your resources and use it. But, the other thing, too, is that it wears off after 20 minutes. So you need to be calling the ambulance as well, because what sometimes will happen is somebody's overdosing on heroin and somebody uses the Narcan, it reverses it. 20 minutes later, the Narcan stops working, they start overdosing again. So you gotta call 911 at the same time.
I'm not seeing any questions here. Here we go. Is there a most prevalent COD or top 3, 5, or 10 CODs?
Yeah, so there's, it varies with substance. So for example, bipolar disorder, the most common co-occurring mental health disorder is actually bipolar disorder. So there isn't really, in terms of opioids, I don't actually know for certain which one is the most common with that particular. I can tell you from my own personal experience, I see really high rates of post-traumatic stress disorder, especially what we call chronic post-traumatic stress disorder, so people that grew up in environments with a lot of physical abuse, a lot of sexual abuse. I see that in like the majority of the patients that I work with, so anxiety disorders, mood disorders. Schizophrenia, we don't tend to see as much opioid use disorder as we do cocaine or marijuana use disorders in those populations, but you still do see it from time to time.
Here's another question. Is such data being compiled by any agency?
I have to imagine that it is. So that NESARC study that I referenced, it is a reference from 2004, and I did go back and try to update that, and I wasn't successful in finding more recent data. I would imagine that if there was a follow-up to the NESARC study that I cited, that they would probably have that information.
Great. Hi there, and many thanks for a terrific and insightful talk. Are there any psych medications contradicted or
contraindicated? Yeah.
Sorry.
Well, the big one is that, so a lot of these medications, buprenorphine, methadone, they can cause respiratory depression, and so medications that can make respiratory depression worse, like benzodiazepine, so things like Xanax, Klonopin, Ativan, those are you generally try to avoid that. I will say it's not what we call an absolute contraindication, and there are some people where you have to weigh the risks and the benefits, and if you don't want to necessarily withhold buprenorphine treatment from somebody just because they're on a benzodiazepine, but I do keep a really close eye on that. The only deaths that have ever been reported on Suboxone, people were also on benzodiazepines as well. And then also you would want to look at sometimes, so methadone can have an effect on the heart rhythm, and so also a lot of our psychiatric medications can have an effect. So you want to make sure somebody's tied in with primary care as well, and getting their EKGs and lab work done.
Right. I'm not seeing any more questions here. You know, if you do have a question, we can, and you would like to either email it to me or to Dr. Harrington. Actually, I think my email, or you know what, we could type it right in here if you were willing to. I don't know, do you want to try doing that? So Dr. Harrington can put her email address.
Yeah, I noticed another question coming up about Vivitrol not being as effective. And just to sort of touch on that, because it's an opioid antagonist, you're not really getting as much control of the cravings as with things like buprenorphine, Suboxone, and methadone. You know, that being said, I think it's so important to tailor the treatment to the patient that you're working with. There are some people who Vivitrol is a fantastic option and they respond really well to it and they do great. There are other people that they need methadone, and I think that's why it should be determined by a medical professional, not necessarily a you know, a judge or something along those lines.
So the materials that you will be receiving with the recording will have our email addresses on them as well. I do see another question about graphic novels. Will they be available in other locations? And to be honest, I don't know the answer to that question. Matthew No is the person in our organization who runs our graphic novel book club kit program. So he would be able to answer that question for you, and his email address will be, it was part of the slide presentations. Actually, I can go back. There it is, matthew.no@umessmed.edu. All right. And I just wanted to, you know, thank you very much for attending this webinar, and I especially want to thank Dr. Harrington for sharing her work with us. I also wanted to let you know that the MLA is offering credit for attending this webinar, but you need to fill out an evaluation in order to receive that credit. So here is the link to that survey and the enrollment code. And I also will include additional information about how to go about getting your certificate for this course. It'll be included in the package of information from this class. All right, thank you, everybody. And we'll see you in January at the next webinar, January 9th. All right, goodbye.